Hi all, my name is Emily Kugel, and today I will be discussing my project entitled Comparison of Learning Priorities of Pediatric and Emergency Medicine Residents Rotating in the Pediatric Intensive Care Unit. I have no financial disclosures, and this study is IRB exempt. The ACGME sets and enforces standards for U.S. residency programs via program requirements for each specialty. The ACGME requires both pediatric and EM residents to rotate in the PICU, but does not specify how those PICU rotations should contribute to program requirements. There is a significant knowledge gap in literature regarding the learning needs of residents in the PICU. Pediatric studies focus on curriculum evaluation and delivery strategies rather than identifying resident needs. While EM residents were present in several pediatric cohorts, no publications directly address EM resident learning needs in the PICU. And finally, no publications were noted to assess what PICU faculty expect residents to learn during a PICU rotation. The CHM PICU oversees residents from 10 programs, including 4 pediatric and 6 EM programs. At the start of this project, each program's PICU rotation learning objectives were reviewed and noted to be quite variable. While some programs list specific clinical skills, procedures, and pathophysiologies to be exposed to in the PICU, some programs provide broad goals regarding exposure to pediatric critical care. Ultimately, the variability of ACGME requirements and program-specific learning objectives creates a challenge for host PICU departments when developing a resident curriculum to meet the varying goals of all involved programs and residents. Thus, our specific aims were to assess the PICU resident learning expectations of pediatric and EM residents as well as PICU faculty, and to compare the assessed expectations both between resident subgroups and between faculty and resident groups. We hypothesize that EM and pediatric residents will differ most in terms of procedural learning expectations in the PICU, and that PICU faculty will have different learning expectations than both pediatric and EM residents in the PICU. To investigate our aims, we conducted a cross-sectional survey of PICU faculty and residents. Faculty were surveyed once with separate responses for pediatric and EM residents. Residents were surveyed twice, once in the beginning of their PICU rotation and once in the final week. Resident surveys were comprised of 3 parts. Survey questions and needs assessment topics were generated to reflect common skills, medical topics, and procedures cited across pediatric and EM ACGME requirements, as well as a program-specific learning objectives. 23 medical topics and 8 procedures were selected for the needs assessment. Respondents first ranked for each topic the level of importance to learn in the PICU rotation on a 5-point Likert scale, and then selected the top 8 medical topics and top 3 procedures they would prioritize learning in the PICU. Knowledge test questions were selected from the available prep pediatric questions to reflect highly anticipated priority topics. Faculty surveys contained 2 needs assessment only, 1 each for pediatric and EM residents. Following data collection, we utilized Fisher's exact tests for our data analysis, with responses dichotomized into 2 groups, important and unimportant. Regarding demographics of the 13 surveyed PICU faculty members, note that all attendings who have worked at institutions other than CHM have experiences working with both pediatric and EM residents. Our pre-rotation resident cohort consisted of 50 surveyed residents. Note the equal split of 25 residents in each specialty, as well as varied representation of career plans in both pediatric and EM fields. Most surveyed residents were on their first PICU rotation, as only categorical pediatric residents returned to the PICU. Regarding the individual ranked priority or individual ranked importance of medical topics by faculty, EM, and pediatric residents. For the 2 significant p-values demonstrated on the first half of medical topics, we can interpret that faculty were significantly associated with placing higher importance on non-invasive ventilation and DKA than pediatric residents. However, it is more notable that the vast majority of medical topics do not yield a significant association between ranked importance level and responder subgroup. This trend continues in the second half of medical topics. We can note that the pediatric residents are associated with higher ranking of brain death examinations than both faculty and EM residents, but for the majority of individual medical topics, there is not a significant association between ranked importance level and subgroup of responder. This shows that subgroups generally place similar importance on the same topics. This is again reflected in how each subgroup selected their top 8 priority medical topics. Note that EM residents and pediatric residents generated the same list, while faculty generate the same list regardless of specialty. Both residents and faculty identified shock and PALS as priority, but the other 3 topics varied between resident and faculty groups. The variation in those 3 different priority medical topics between residents and faculty can be better delineated by these figures, in which bars represent the percentage of responders who selected each medical topic as priority. The selected topics here were marked priority by a larger percentage of residents in blue than faculty in orange. These topics included ARDS, mechanical ventilation, sedation, and more. Meanwhile, this figure depicts medical topics which were selected as priority by a higher percentage of faculty in orange than residents in blue. These topics included status asthmaticus, DKA, status epilepticus, among others. Compared to medical topics, individual procedure rankings possess more frequent significant associations between responder groups and ranked importance. Note that faculty are significantly associated with higher importance of resuscitation skills such as IO access, back valve masking, and IV placement when compared to respective resident groups. Meanwhile, the resident groups are associated with more advanced procedures than faculty cohorts, such as arterial lines, central lines, and chest tube placement. Between the resident subgroups, pediatric residents were associated with higher ranking of back valve masking, while EM residents were associated with a higher ranking of intubation, central line placement, and chest tube placement. The frequent variation in ranked importance of procedures is again demonstrated when looking at the top 3 prioritized procedures selected by each subgroup. Note that no 2 lists between resident or faculty groups are the same. EM residents in particular identify a unique list of procedures, which includes central venous access and chest tube placement, which are prioritized by no other subgroup. Regarding medical topic teaching in the PICU, we can summarize that pediatric and EM residents generally have similar learning expectations that differ from the expectations of faculty. Many of the topics with high relative prioritization by residents reflect topics used on a daily basis in PICU medicine, which likely reflects residents' desire to prepare for day-to-day success during their rotation. Faculty prioritized topics reflected more common yet high acuity pediatric pathologies, such as seizure, asthma, and DKA. This likely reflects faculty goals of preparing all residents to identify and stabilize critically ill children in their future careers, while not emphasizing PICU-specific skills to residents who will take many different career paths. Procedurally, resident and faculty groups expect different education in the PICU. Residents and faculty similarly recognize specialty-specific procedures such as LP for pediatric residents and intubation for EM residents. EM residents additionally expect specific procedural learning such as chest, central line, and chest tube placement, which potentially relates to the limited opportunities to experience these procedures in pediatric patients through training. Meanwhile, faculty generally prioritize emergency resuscitation skills most pertinent to each specialty, such as back valve masking, IO access, and IV placement. Overall, our results supported our original hypothesis. We also identified a common theme of the disconnect between goals of PICU rotation education. While faculty prioritize pediatric knowledge and high urgency procedures, residents prioritize topics and procedures which help prepare them for PICU rotation success, despite that many residents will not require this level of PICU knowledge in their future careers. While our results suggest this gap in understanding, it's difficult to know how to address this gap, namely in how heavily to weigh each group's priorities and combine expectations into a unified PICU education curriculum. We do acknowledge the limitations of our project. This is a single center study which reflects the perspectives of one PICU faculty group and residents rotating in one PICU. We also had limited time and scope to evaluate validity and reliability of our developed surveys, and we did not survey EM faculty at this time. The results discussed today reflect phase 1 of our larger study design. We have since entered phase 2, beginning with the implementation of our new PICU resident curriculum, which included incorporation of the results discussed today, along with ACGME program requirements and program-specific learning objectives. These are my references, and thank you for your time and attention.